Okay, hello everyone. So we'll talk about hernia examination, which is in theory an extension of the abdominal exam. So standard, we would use wiper plus IPPA, but you do not have to go through the entire IPPA. With that said, you would require a chaperone for hernia examination because it is an intimate examination. Now, with that said, the hernia also is commonly, groin hernias, commonly part of the urogenital examination. So you may find out that that's also required in urology or general surgery. Now let's get to the script. So the script for hernia examination is what I like to call standing, sleeping, anatomy and assessment, or what you can remember alphabetically as SSAA. Now, with that said, the exposure for the hernia exam is from the waistline to the mid-thigh. So once you've exposed the patient, with the patient standing, you want to demonstrate two things on inspection. You want to demonstrate the visible cough impulse. You ask the patient to look away and cough, and you look at the groin area for something like that. That would tell you if there's a hernia there, because that increases the intra-abdominal pressure, and that sort of like the hernia try to poke out. The next thing is you want to do something like this bilaterally and ask the patient to look away and cough, and you want to demonstrate what is called a palpable cough impulse. So when you do that, you feel the hernia hit your hand, depending on the part, whether it's unilateral or bilateral hernia. So once you've done that, depending, some hernias are so big that it protrudes. Usually most books would not advise you to attempt to reduce the hernia when the patient is standing, because gravity would work against you. So you want to ask the patient to lie down, and then the hernia may reduce. A caveat here is, in a clearly visible protruding hernia, there may not be a need for a palpable. You go ahead and demonstrate the visible palpable cough impulse, visible cough impulse and palpable cough impulse as well, because of you want to confirm there's a hernia and not something else. So you ask the patient to lie down. The hernia may reduce spontaneously, or you ask the patient to attempt to reduce the hernia. Now, if it reduces spontaneously, that's fine. If the patient attempts to reduce it, that's fine. Or you can attempt to reduce the hernia yourself. These are the three options in the elective setting. So once you've done that, you want to delineate the anatomy. And it's important here to look for the anterior superior iliac spine laterally and the pubic tubercle medially. So one of the ways you can trace the pubic tubercle is look for the umbilicus, go below until you feel a protrusion in the pubic symphysis area, and then go laterally until you feel sort of a high indentation. The other thing is, some examiners would ask you to put the adductor muscles under contraction and trace it upwards that way, and then that would be the pubic tubercle. Now, the inguinal ligament run across that, and the inguinal canal is on the medial end of the pubic tubercle. Now, once you've done that, you want to delineate two important anatomic relationships, and the first one is the mid-inguinal point and the midpoint of the inguinal ligament. Now, why are these two important? The mid-inguinal point is the midpoint of an imaginary line from the anterior superior iliac spine to the pubic symphysis. And the midpoint of that, the mid-inguinal point, is where you can palpate the femoral pulse. Now, the midpoint of the inguinal ligament is the mid-distance between the anterior superior iliac spine and the pubic tubercle, and that's where the internal ring of the inguinal canal lies. So the femoral pulse is just lateral to the midpoint of the inguinal ligament. Once you delineate that, you want to decide whether the hernia is direct or indirect. So the concept of the direct and indirect hernia is the direct hernia would pass through the internal and external ring. Usually the indirect hernia passes through the external and internal ring, and usually it's otherwise called the inguinoscrotal hernia. The direct hernia is coming from a weakness in the posterior abdominal wall in the Hessenberg's triangle. Therefore, that is the main difference. So what you want to do is to delineate this. So you want to reduce the hernia, put a finger and occlude the internal ring and ask the patient to cough. If it's an indirect hernia, the hernia would not recur. If it's a direct hernia, the hernia would recur. Now that helps you to differentiate direct and indirect inguinal hernia, but it doesn't help you to differentiate the femoral type of hernia. So what do you need to do? The differentiating point of the femoral hernia and the inguinal hernia. So you look for the pubic tubercle, you look at the relationship between the hernia and the pubic tubercle. If the hernia is below and lateral to pubic tubercle, that is likely a femoral hernia. If it's above and medial, that's an inguinal hernia. So once you've delineated the anatomy, typically that would conclude the hernia examination. You can offer to do a full-blown abdominal exam, looking for the possible reasons for the hernia. You can also offer to do a digital rectal exam, a urogenital exam, and any other indicated exam. So let's summarize. The script for the hernia exam is wiper plus IPPA. Not all of the IPPA is required. So you have standing, sleeping, anatomy, and assessment. And assessment, like I've taught in my other videos, is through SBA, situation, background, assessment, and recommendation. Thank you for listening, and please like, subscribe, and share the videos.